was actually talking to a friend of mine from Buffalo who was very involved in the community. And he's, 4 years ago, 5 years ago, had a liver transplant. So he's not really hemophilic anymore. That cures it, but he's still very much involved. And we've talked about the gene therapy, about the various therapies coming up. And although it's like the gene therapy sounds really great, oh, one shot and you're done. Well, at least for factor VIII, it's not the life of the dose or the shot is not lasting a lifetime. It's lasting maybe 5 years, maybe 10 years, but it doesn't sound like the cure that we had hoped. Of course, that could be, this first generation stuff. It's, a few years down the line, maybe it'll be much, much better. There's talk of extended half-life factor VIII product, a sub-Q one. I'm like, that sounds interesting to me. So those type of newer products are always interesting. I'm still waiting, though, for the promise that was made decades ago to us, oh, they'll have a pill. Let's see that. Let's see a pill. You just take a pill every day and you're fine. But in the same token, you look at someone with diabetes, and now they have something on their arm and it monitors it and they get it. It's like, could we go in that direction where you wear something on your arm or on your stomach and it just automatically administers it and monitors your levels, and you would just coast along and not have to worry about it. Well, ideal would be the pill, but if that's not possible, a sub-Q, so you don't have to worry about hitting a vein, which, especially in cold, damp weather like we've experienced in the past several days, is difficult. And if you can't get a vein, then you have to, it takes longer. It's more, maybe 2 or 3 sticks to get it. So if we could eliminate that, maybe even a sub-Q method would be great. Or, as I said before, something that you would wear that would automatically monitor and administer factor, or something to get your clotting to work correct so that you maintain a level of clotting that would be acceptable for general life would be great. Well, I can relate to one particular story. We were on vacation, I believe it was out in the Black Hills, and we were going to do a horseback ride. Now, I probably have gotten away with not treating prior to it, but I did, because you stop and think about it. If I'm, get through the ride, that's great. But then for the rest of the day and the next, I'll be laid up because I didn't treat. So a prophylactic treatment was called for, and I did that. If we had something that you didn't have to worry about that, it was just once a week or once every 2 weeks or whatever, the extended life, the extended time in between treatments is very important, I think. It will always impact us. We'll always have something to take, I imagine. It's just, are you going to be sticking a needle in you? Are you going to have something that, that you wear? I think those are the things we have to consider. And whether it's IV or sub-Q, which is huge. The sub-Q is just a game changer, I think.
We continue to see an explosion of new factor therapies, primarily available for prophylaxis for both hemophilia A and B, and potentially also of use in other bleeding disorders. And these cross a number of different categories: factor VIII mimetics, antithrombin knockdown, TFPI inhibitors, protein C inhibitors, and other inhibitors of the anticoagulant proteins in an attempt to rebalance hemostasis. Many of these products are available through subcutaneous injection and offer a different approach. Rather than replacing the missing clotting factor, the approach here is either to substitute for a clotting factor or to somehow rebalance the pro and anticoagulant proteins. We've previous episodes, we've spoken about emicizumab, a bispecific antibody that mimics the function of activated factor VIII. We have additional products in this class, for example, Mim8, that are currently in clinical trials that are a similar structure to this bispecific antibody with slightly different manufacturing approaches, but with a goal of mimicking the role of activated factor VIII. This new product is also administered as a subcutaneous injection, and as I mentioned, is currently in clinical trials to compare the overall efficacy and safety to currently available bispecific antibodies. The goal here is to bring together activated factor IX and factor X to achieve improved hemostasis. With the newer product, it is, though similar in structure, is a bit of an increase in potency. So it may provide overall similar efficacy with a difference in dose. But the manufacturing changes may also improve the degree of hemostasis achieved. And we can often try to measure these with different approaches to assaying thrombin generation through global measures of hemostasis.
Well, I'm going to talk about another product called Fitusiran. Fitusiran is an antithrombin medication. Where did the idea for Fitusiran come from? Well, antithrombin deficiency is a known prothrombotic disorder, kind of the opposite of hemophilia. You don't bleed too much, you clot too much. And there are patients who've been reported, rare patients, who happen to have hemophilia and also inherited antithrombin deficiency. And what was found in those patients is that they don't bleed as much as hemophilia patients bleed, and they don't clot as much as antithrombin deficient patients bleed. In essence, they have rebalanced their clotting system. So in other words, they don't tilt towards bleeding and they don't tilt towards clotting, even though they have mutations in both. So they've kind of canceled each other out, if you will. And so with that history comes Fitusiran. Fitusiran has a unique mechanism of action in the sense that it uses what we call small interfering RNA technology. There are, in fact, a couple of drugs that have now been approved for different uses using this small interfering RNA technology. Fitusiran's small interfering RNA technology essentially is there to inhibit the production of antithrombin. So what we are doing is inducing antithrombin deficiency in a patient on purpose, a patient that has hemophilia. And just like that natural experiment of nature I presented or discussed earlier, the idea here is to rebalance hemostasis so that patients don't bleed too much and don't clot too much. The data for Fitusiran in the phase 3 trials was very encouraging. The bleeding rates were very low. The median bleeding rates for patients with hemophilia A, hemophilia B, with or without inhibitors, so all categories of hemophilia, the median bleed rates were 0. There were some issues with safety. There were a few thrombotic events that occurred, which on the one hand is not too surprising, but on the other hand, we want to try to avoid. There were some other effects related to the liver and the gallbladder and bile production. And in essence, a new dosing strategy was put together to try to reduce the adverse event rate. And that new dosing strategy has worked and has resulted in fewer thrombotic events. And now that is the dosing strategy that is being carried forward in the additional trials. The advantage of this dosing therapy, in addition to reducing adverse events, is that it is a subcutaneous injection every other month. So when it comes to all these new hemophilia treatments that we discussed in previous episodes, other than gene therapy, this one has the lowest treatment burden, being a subcutaneous injection every other month. Some patients will have to increase that to once a month, but most patients continue with every other month. So what about the anti-TFPI agents? That's another category, the anti-tissue factor pathway inhibitor agents. Maybe Stacey, you can discuss those a bit.
So similar to Fitusiran, the idea behind the TFPI inhibitor antibodies is to rebalance the coagulation cascade. So monoclonal antibodies have been developed, and we have 2 products who've come through phase 3 trials, concizumab and marstacimab, that are also administered as subcutaneous therapies, again with the idea of rebalancing the coagulation by reducing the amount of TFPI or tissue factor pathway inhibitor. The clinical trials for these have also shown a marked reduction in median annualized bleed rate, particularly compared to on-demand bleed treatment. But they also have been met with some challenges, particularly in the concizumab clinical trials, similar to what you mentioned in terms of Fitusiran. There have been challenges with thrombotic events. And again, not surprising because there's a careful balance between pro and anticoagulant proteins, but just goes to show that that balance is quite tenuous, even in those with severe bleeding disorders. And careful approach to both dosing of the medication but also dosing to bleed treatments, whether we're using factor concentrates for bleed treatments or whether it's bypassing agents in those individuals that have inhibitors, requires careful monitoring and a careful understanding of the coagulation cascade. We don't have readily available clinical assays to help us measure in clinical practice levels of TFPI or the implications of these types of products, but certainly in the clinical trials, use of global assays of hemostasis, again, thrombin generation assays, can be helpful in looking at the overall impact of these therapies, and translating that into clinical practice, if and when these become licensed, will be really important. From a day-to-day perspective, subcutaneous, whether it's daily or weekly or monthly, is certainly less burdensome to some extent compared to IV therapies. And when we're going about our day-to-day lives for prophylaxis, seem to confer good bleed protection. But I think particularly at times of significant injury, times of significant illness, when we have a deviation from our usual homeostasis, the relative importance of the pro and anticoagulant balance shifts and can be difficult to measure in routine clinical labs. And so will require additional education and knowledge amongst our emergency room colleagues, our ICU colleagues, to help ensure that we optimize that right balance between too much bleeding and too much clotting in order to keep patients safe.
Yes, and then the last molecule that we want to discuss in this section on non-factor therapies is now in phase 3 clinical trials as well. It's a little further behind in development, and it's called SerpinPC. So we discussed the thrombotic events we've seen with Fitusiran, with concizumab, and again, mitigation strategies have been employed to reduce that. But the idea behind SerpinPC, at least the idea, is that it can induce hemostasis, in other words, improve hemostasis, reduce bleeding, but without increasing the risk for thrombosis. So again, that is the idea behind the molecule. And the way that the company has developed this and explained this is that SerpinPC is inhibiting the activated form of protein C. Again, one of their coagulation inhibitors, but it's not inhibiting the protein C pool. So in other words, only the activated form of protein C that is critical in inhibiting factor V and factor VIII is inhibited, and the rest of the protein C remains intact. Now, in the phase 1 trials, hemostasis was improved in patients that were participating in that trial, mostly significantly improved, and so far thrombotic events have not been seen. But it's still early days yet, and now the phase 3 trial is going on. And I think we would like to see really some proof of that with a large number of patients receiving the molecule for a long period of time before we are comfortable and convinced that the mechanism of action does indeed imply improved hemostasis without the risk for thrombosis. So yes, we're anxious to see that data. The trial's accruing patients right now in phase 3, so not sure exactly when that will conclude and when we'll be able to see that data, but it is a little bit further behind. But for a molecule that's coming in later, it's going to need to have some sort of advantage. And the dosing, again, it is subcutaneous, as all these drugs are. The dosing is either weekly or monthly. I think they're looking at every 2-week dose as well. So similar to most of the drugs we have that we've been discussing. But really the advantage will need to be in the safety. And if they are right, and they may be, that's certainly something that is going to put that drug very strongly on the radar because, of course, safety is critical. Yes, we must control bleeding. That's the number one. But if we can control bleeding without increasing the risk for thrombosis, with all of this group of drugs that we're calling rebalancing agents, that would be significant advantage for SerpinPC.
Yeah, and certainly protein C not only has an important role in coagulation, but especially compared to some of the others, a particularly important role in inflammation as well, and that sort of cascade. So to your point, I think having an adequate sample size participating in the clinical trial to help us identify what might be less common events, particularly on a day-to-day basis. These types of things may not come into play, but certainly as we go through flu season, COVID, these types of things that really sort of alter our homeostasis and put us in different pro and anticoagulant balance, looking at these molecules critically in those types of patients, in those situations for our severe hemophilia patients will be important.
So just to summarize about these emerging non-factor therapies, they are all subcutaneous, so that's certainly an advantage. And they basically fit into one of really two categories: factor VIII mimetics, so a future type of factor VIII mimetic that's different than emicizumab that we have now, or the other category we're calling, for lack of any better type of term, rebalancing agents, because again, they're attempting to rebalance the hemostatic system by negatively impacting on coagulation inhibitors, which inhibit, of course, the coagulation system. And so those rebalancing agents can either be anti-antithrombin, which is Fitusiran, anti-tissue factor pathway inhibitor, which is concizumab and marstacimab, or anti-activated protein C, which would be SerpinPC. The other main advantage of the rebalancing agents is the fact that because they're not working on a specific coagulation protein like factor VIII or factor IX, they in theory should be, and in practice so far in the clinical trials, have been used in patients with hemophilia A and B with and without inhibitors. So they can sort of, in a way, be applied universally across hemophilia patients without having to think, does this patient have an inhibitor, or does this patient hemophilia A or B? They can be used for all those patients. So continue to be on the lookout for the data that is emerging on these therapies, and certainly they're going to be added to our armamentarium and give us more and more options for patients in the future to individualize treatments, as we discussed in prior episodes.
So, Dr. Baggio, what types of challenges are you seeing in your current patient population that are better addressed by some of these new therapies compared to what we currently have available?
The patients who are interested in doing the novel therapies, especially those who have poor intravenous access, they're the ones who have been very excited about getting the newer subcutaneous therapies. They have difficulty doing the intravenous infusions themselves. I do have many patients that only have one arm or have absolutely no IV access that they find to be reliable, or over time, they've been doing these infusions for 30, 40, 50 years now, and their veins just are not able to keep up with the constant infusions. Those are the patients who have been excited about doing the subcutaneous therapies and the very long-acting therapies that makes their infusion burden less. It's also good for them that they see their grandchildren, in many cases, are already on some of these subcutaneous therapies in the factor VIII realm, and they're seeing how their nephews, nieces, in some cases, and their grandchildren are not having any bleeds at all and have a totally different childhood than they experienced. And that gets them excited to perhaps see if that would be helpful for them.
So I think the promise of these new therapies is quite exciting in that we can apply them to multiple bleeding phenotype patients, multiple types of hemophilia. But as we shift from just replacing the factor, it comes with these new therapies come with some new challenges. So previously, if I had a patient who I suspected was bleeding or had an injury, if I sent them to the emergency room, they could pretty easily explain to the emergency room provider, I have hemophilia. We could check a PTT or a factor level. Emergency room providers were often somewhat knowledgeable, at least with the fact that there were factor concentrates to replace them with. But as we have all of these new emerging therapies, I think it's very challenging for emergency room personnel, for other hospitalists and ICU personnel to keep up with all of the different types of therapies that hemophilia patients may come in on, and may not recognize that some of these therapies interfere with the usual coagulation assays, rendering them not reliable in terms of assessing hemostasis, or that we can't just measure a factor VIII level or a PTT as a measure of how effective the hemostasis is, and that we may have other approaches to having to improve antithrombin levels or rebalance the risk of clotting that's there. And so I think ongoing kind of education, both of patients and families, but also of our colleagues, is going to be really critical to help keeping patients safe on these novel therapies.
Yeah, absolutely. And you touched on the laboratory aspects, and the way that these drugs work is, on the one hand, they may not impact certain laboratory tests in hemophilia, which might be a good thing. On the other hand, people might expect, well, if I'm on this therapy, then my hemophilia lab tests should be better, and they're not better because we're not really affecting that side of the coagulation system with the rebalancing agents in particular. And so, yeah, there's going to be significant laboratory challenges. In addition, there are going to be laboratory requirements for some of these drugs. With emicizumab, we don't have to do any lab testing. With efanesoctocog alpha, there's no requirement for any lab testing. But with concizumab and with Fitusiran, there's going to be a requirement for therapeutic drug monitoring, essentially. So that adds another element of complication to using these drugs. And then the other thing is if a patient starts with one of these drugs, some of them have a really long half-life. So I don't know if, Stacey, you want to touch upon, what it means to start one of these drugs, and that if you're not totally satisfied with it, how we might even think about stopping it and switching.
Absolutely. I mean, with factor concentrates, they have such a short half-life that if the strategy isn't working well for you, we can change the dose, change the infusion frequency, change the factor concentrate, all within a few days for a week, and be off and running with a new approach to prophylaxis. But with some of these novel therapeutics having half-lives of 30 plus days, 5.5 half-lives takes you to 6 months practically. And that's the average that these drugs will still be in your system. So when you're rebalancing, changing the way that you rebalance, having difficulty in measuring sort of where you are, how well rebalanced you are, and shifting to those other therapies, I agree, is going to be quite a challenge, and will depend a bit on the individual, what bleeding phenotype they're experiencing that might be prompting us to rebalance, and what assays are available given the therapy that they're trying, to sort of gauge where they are in terms of their pro and anticoagulant balance.
So practically speaking, there's definitely these new challenges with these drugs. The challenges, as you mentioned, of the emergency management, it's going to be not the same. With factor VIII, it's if you have a breakthrough bleed, just give a little more factor VIII. With these drugs, there's added challenges to that. The laboratory measurement, whether you want to do it or don't want to do it, for some of them you'll have to do it, and how that's going to pan out is going to be an additional challenge. And then the switching from one product to the others is far less straightforward. So while these emerging therapies certainly are providing new options and good options, they also come with their own set of challenges as well.